Welcome to the discussion of catatonia. Hopefully this discussion will help to broaden your knowledge and understanding of catatonia beyond that of a fixed set of symptoms to the knowledge of catatonia as a neuropsychiatric syndrome in and of itself. So catatonia was originally defined by the medical literature many years ago as a disturbed mental state involving immobility or abnormality of movement and behavior. It was first identified in 1874 by Kalbum, and it was described as encompassing the presence of dystonic, stiff, and rigid symptoms, which kind of predominated our view of catatonia for a long-standing period of time. Categorically, the use of the term catatonia was grouped into the schizophrenias, if you remember schizophrenia catatonic type. But the lack of diagnostic clarity has hampered research on catatonia for a long time, and we know that it goes far beyond schizophrenia. And within the last decade, it became clear that catatonia had to be separated from the schizophrenias because it incorporates far more than its application in a population of patients who struggle with schizophrenia. It's actually more highly prevalent in mood disorders. It can also be seen in other medical conditions as well. So again, classically thought of as dystonic, stiff, or rigid posturing, it is now identified as far more than that and one of the most complex psychiatric conditions. And more widely defined now, or more accurately defined, as a psychomotor syndrome presenting with a large number of different motor signs and even vegetative instability. So in order to advance our knowledge and understanding of Catatonia syndrome, we need to look into the DSM-5 diagnostic classification and the criteria for diagnosing Catatonia syndrome, which consists mainly of 12 different symptoms. So the first symptom is stupor. It's reduced psychomotor or no psychomotor activity, or no active relating to your environment as a whole, extreme passivity, and marked hypokinesia. Catalepsy, which is passive induction of posture held against gravity and some stiff, rigid posturing. Waxy flexibility is when an individual allows themselves to be positioned passively, so that passive range of motion, and that passive positioning is held for a period of time even though the individual lets go of the posture. So an individual or a practitioner is taking somebody through passive range of motion, and the individual holds, or the patient holds themselves in that position even though the practitioner removes their hands from posturing the individual. Mutism is very little or no verbal utterances. This includes inaudible whisper. Nothing identifies or incorporates the sense of negativism more than a toddler, as you can see in the picture. And this is opposition or resistance, or sometimes no response at all to instructions given. Posturing, or spontaneous active maintenance of a posture against gravity, is what's demonstrated as well in the picture below. And also included in the diagnostic criteria are mannerisms, odd circumstantial character of normal actions, or stereotypy. That's the repetitive, abnormally frequent, non-goal-directed movements, often seen in autism spectrum disorders, with the flapping of the hands repeatedly is sometimes one example of stereotypy. The last four symptoms, as identified by the diagnostic criteria, are agitation, grimacing, echolalia, and echopraxia. Other signs may include staring, ambitendance, which is acting in an opposite way of direction, iterations, repeating the same thing over and over, no, 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 or I sit down, I sit down, I sit down. Stereotypes, like we said, mannerism, overactivity or excitement, and impulsivity or combativeness. Other symptoms consistent with this syndrome also noted and overlapping to which was previously described by the 12 diagnostic criterion inherent in DSM-4: oppositionalisms, automatic obedience, when an individual or a practitioner says to a patient, "Stick out your tongue," and they stick out their tongue. Echo phenomena like copying words or movements, verbigeration, continuous or directionless repetition of single words, withdrawal or refusal to eat or drink, turning away from the examiner only to return in a previously occupied position, no or limited eye contact, refusal to take in food or drink when offered. Also, symptoms that might tip us off to take a closer look at this as a catatonia syndrome. So there are 3 subtypes of catatonia, and I'm going to move fairly quickly in an effort to conserve time, as you'll have a copy of these slides and can read through them at your leisure. Stupor. So there's a stuporous catatonia. It's a motionless or apathetic state, which is characterized by little or no interaction with the external environment. Catatonic excitement, which is cited as the most dangerous mental state in psychiatry. It's constant purposeless agitation and excitation. And finally, malignant catatonia, and this is really important as it's typically an acute onset, and we see it with acute onset of excitement, fever, and autonomic instability or delirium. It can be fatal. And again, the malignant catatonia presentation is one that is highly overlapping to overlapping with neuroleptic malignant syndrome, where you find or you observe a fever, autonomic instability, and the likes. So malignant catatonia is one of the most studied forms or subtypes of catatonia because of its severity. It does carry a fairly high mortality rate, so 25% of individuals diagnosed with malignant catatonia will decease, and again characterized by the development or sudden onset of autonomic disturbance, labile blood pressures and heart rates, hyperthermia, and diaphoresis. This is truly a medical emergency, and malignant catatonia requires ECT intervention and, as noted, is a medically emerging situation. The prevalence of catatonia varies anywhere between 5.3% and 19%. Generally in the literature, this wide variation can be boiled down to an overall prevalence rate of about 10% in the general population. However, in a population of psychiatric hospitalized individuals, there's probably a slightly higher prevalence rate of catatonia syndrome. Despite a growing scientific and clinical interest in catatonia, its precise definition remains debated, and this has really hampered our knowledge and understanding because of the lack of operationalization has really hindered us to be able to study catatonia and make advances forth in research. So there's several catatonia rating scales, and there's a number of ways of diagnosing catatonia. The one that we use is the Bush-Francis Catatonia Rating Scale. The Bush-Francis consists of 23 items. The first 14 items are the Bush-Francis Catatonia Rating Inventory or Screening Inventory. And on the first 14 questions of the Bush-Francis, if any 2 of those questions are positive or they're affirmed, any 2 of those observations are positive observations or scored positively, that certainly gives rise to taking a closer look at catatonia as a whole. The remaining items, or actually items 1 to 23, are scored on a 0 to 3 point scale, and it's generally accepted that the higher the score, the more severe the case of catatonia. So how does catatonia happen? It's a very good question. There's certainly some things that neurologically defy our simple explanations. Currently, there's no kind of pathophysiology which has been identified that underlies each form or the subtypes of each catatonia syndrome. But the pathobiology is suspected to lie in the GABA system, and in glutamate, which may be why it's responsive to benzodiazepines. So some of the neuroimaging report reduced resting state activity and reduced task activation in the motor areas of the frontal and parietal cortex. Similarities between catatonic symptomology and extrapyramidal side effect or extrapyramidal syndrome could also give rise to the notion that there's trouble in the mesolimbic and mesostriatal dopaminergic pathways and an imbalance in the frontal lobe basal ganglia brainstem system, which is thought to be involved. Likewise, as noted, excessive glutamate activity is believed to be involved, which may give rise to the notion of why it's so responsive to benzodiazepine medications. And when first-line treatment options fail, NMDA antagonists such as amantadine or memanta are also used. So there's a wide variation, and there's no kind of clinical prescribed treatment course for catatonia. However, one of the first things that needs to be withheld or used with an abundance of caution is neuroleptic medication. At times, because these symptoms can advance to a malignant catatonia, and those symptoms inherent of neuroleptic malignant syndrome often overlap the symptom profile for catatonia syndrome. It's not advised to use neuroleptic medication because this can be lethal in catatonia. They should be not used or used with an abundance of caution. So identifying the treatable physical disorders that might be precipitating or contributing to catatonia syndrome is certainly advised. And a trial of lorazepam is also advised. This is therapeutically safe and effective in 80% of the cases. And sometimes what's been utilized is a Ativan challenge or an Ativan trial test, where an individual is given 2 milligrams of Ativan, and if they are, or the signs are reduced by 50% within the first hour or so, then that's a successful trial. If the patient fails to respond to Ativan, ECT is needed, and earlier use of ECT is recommended, especially if autonomic instability is present. In conclusion, catatonia has always had a blurred place in psychiatry since it was first introduced within the literature. And that blurred place is part and parcel of the pathophysiological process, which remains very much unclear to us, which is why treatment or effective treatment for catatonia is elusive. For a long-standing period of time, it had been incorporated within the group of schizophrenias and underdiagnosed, but it's more often known to be associated with mood disorders and can be also associated with a wide variety of medical conditions as well. So the hope is that the new classification of catatonia will foster a greater understanding and more clinical research and neuroscientific approaches by testing catatonia in various populations and applying stringent criteria might give rise to some more advanced protocols in terms of addressing and treating catatonia. The scarce number of prospective trials will hopefully increase over time, and as more trials increase, we will be encouraged with a more precise concept of catatonia syndrome as a whole and understanding of how to treat it.